Welcome to another deep dive. Today we're tackling a topic that's, well, absolutely foundational to patient care: fluid, electrolyte, and acid-base imbalances. If your nursing textbooks make this feel like just an overwhelming mountain of information, you're definitely in the right place.
Absolutely. Our mission today is really to cut through that complexity. We're drawing from some great resources like Lewis's Medical Surgical Nursing and sort of distilling the most critical insights you need.
So understanding how these imbalances actually happen.
Exactly, how they happen, what they look like, and maybe most importantly, your role as a nurse in, assessing and managing them.
Okay, think of this as your focused roadmap then, to truly get a topic that really underpins almost every major illness or injury you'll encounter. We'll explore the body's incredible balancing act, then zero in on what happens when things go awry with fluid volume, major electrolytes like sodium and potassium, and that delicate dance of acid-base balance. We're emphasizing the nursing process using practical language.
Yeah, trying to unravel those complex medical terms.
Right. So let's unpack these vital concepts for your practice. Okay, let's set the stage with the body's constant goal: homeostasis. It's that stable internal environment our bodies fight to maintain, right?
That's exactly it. And at its core are body fluids and electrolytes.
The transport system.
Pretty much, yeah. Body fluids are the ultimate transport system, moving oxygen and nutrients in and waste products out. Water makes up a huge portion of our body weight.
But it varies.
It does vary, yeah. By age, lean body mass. For instance, older adults and women generally have a slightly lower percentage, and that can actually make them more vulnerable to fluid shifts.
Interesting.
And when we talk about these fluids, we mainly think of two big compartments.
Inside and outside the cells, is that it?
Exactly. Intracellular fluid, ICF, that's the fluid within our cells, maybe about 2/3 of total body water. The rest, the other third, is extracellular fluid, or ECF. That's outside the cells.
Okay.
And ECF then further divides into interstitial fluid, that's the fluid sort of bathing our cells, and intravascular fluid, which is the plasma in our blood vessels.
And understanding that distinction is key.
It's crucial, yeah, because imbalances in one compartment often have these ripple effects on the others. And here's a really key clinical insight. A sudden change in body weight, often your most reliable indicator of fluid status.
Ah, right.
Remember, 1 liter of water weighs about 2.2 pounds, or 1 kilogram. So a patient losing, say, 4.4 pounds overnight.
They've likely lost 2 liters of fluid.
Exactly. It's a quick, powerful assessment tool.
Okay, and these fluids aren't just plain water. They're bustling with electrolytes, right? Electrically charged particles.
Yes, these are the heavy lifters, you can say. Electrolytes are substances that split into ions when they're in water. We have cations, positively charged.
Like sodium, potassium?
Sodium Na plus Vis, potassium K plus S Vis, calcium K2 plus Ma, magnesium Mg2 plus Fis. Those are the big ones. Then there are anions, negatively charged, things like bicarbonate HCO3, chloride Cl, and phosphate PO43.
And they're distributed differently.
Very specifically, yes. What's fascinating is their distribution. Sodium is the dominant serication in the ECF outside the cell. But inside the cell, potassium rules. This specific balance is absolutely essential for, well, pretty much every cell function. Nerve impulses, muscle contractions.
So the body's constantly moving these things around. How does it manage that? This incredible dance between compartments.
It uses a few key processes. There's simple diffusion. That's kind of like sugar dissolving in your coffee molecules, just spread out, high concentration to low, no energy needed.
Passive.
Totally passive.
Really?
And the facilitated diffusion is similar, but it needs a little help, like a protein doorway, to get larger molecules across. Glucose is a good example. Still passive, though.
Okay.
But then there's active transport. This is where cells actually use energy, ATP, to pump molecules against their concentration gradient.
They're going uphill, basically.
Exactly. The classic example is the sodium-potassium pump. It's constantly working, pushing sodium out and pulling potassium in. Vital for cell volume, nerve function.
And for water itself, this is where osmosis and osmolality come in, which is, yeah, really interesting.
It truly is. Osmosis is just the movement of water across a semi-permeable membrane. It moves from an area of lower solute concentration to one of higher solute concentration, trying to balance things out.
And that pull is osmotic pressure.
That pulling force is osmotic pressure, yes.
Yeah.
We measure this concentration in body fluids by osmolality. Think of it as how concentrated the fluid is. A value over, say, 295 millisem QRE usually means there's a water deficit, too many solids for the amount of water.
Dehydrated?
Could be, yeah. And below 275 millisem QRE, you're likely looking at water excess. This whole concept is absolutely vital for understanding IV fluids.
Right, the different types.
Exactly. Isotonic fluids, like normal saline, have a similar concentration to our cells, so there's no major net water movement. Hypotonic fluids are less concentrated. Water moves into cells, which can make them swell.
Potentially dangerous.
Can be, yes. And hypertonic fluids are more concentrated, so they pull water out of cells, causing them to shrink. The nursing takeaway here is huge. Picking the right IV fluid depends entirely on understanding these principles to avoid dangerous cellular shifts.
Beyond that, we have other pressures influencing fluid exchange, especially down at the capillary level.
Yes, absolutely. Hydrostatic pressure is basically the pushing force of fluid.
Right.
Think of blood pressure pushing water out of capillaries. And counteracting that is oncotic pressure. That's the pulling force, created mainly by large proteins like albumin in the blood plasma. It draws fluid back in.
And the balance determines where fluid goes.
It's all about the balance of those two forces. It determines whether fluid moves into your tissues or stays in the vessels.
And when that balance goes wrong, we see things like edema. What's causing that swelling?
Right, edema. That visible swelling is just an abnormal buildup of interstitial fluid. It can happen if that hydrostatic pressure gets too high.
Like in heart failure.
Heart failure, fluid overload, yeah, pushing fluid out. Or it can happen if oncotic pressure drops too low, like with low albumin from liver disease or maybe malnutrition. There's less force pulling fluid back into the capillaries.
I see.
We talk about fluid spacing. First spacing is just normal fluid distribution. Second spacing is that edema we just discussed. But the really critical insight for nurses is third spacing. This is when fluid collects in areas where it's functionally lost to the circulation.
Like ascites.
Ascites in the abdomen is a perfect example. Or fluid from severe burns. The patient might look swollen, puffy, but their actual intravascular volume could be dangerously low.
Wow, that's a challenge for assessment.
It really is.
Yeah.
A significant challenge.
Okay, so our bodies have these truly amazing systems to regulate water balance and try to prevent these shifts. Who are the key players in that constant balancing act?
It's like a finely tuned orchestra. The hypothalamus and pituitary gland are definitely key players.
Right.
Osmoreceptors sense changes in fluid concentration.
They trigger thirst.
They trigger thirst, which is really our primary defense against dehydration. And they signal the release of ADH, antidiuretic hormone. ADH tells the kidneys to reabsorb more water, making urine more concentrated.
And the kidneys themselves.
Oh, the kidneys are central regulators.
Well-
Absolutely crucial. They adjust urine volume and electrolyte excretion constantly. When kidney function's impaired, you almost inevitably see fluid and electrolyte imbalances. It's a direct link.
Hormones play a big role too, right? You mentioned ADH.
Absolutely.
Yeah.
The adrenal cortex secretes aldosterone. Aldosterone promotes sodium retention. And remember, water tends to follow sodium. This is heavily influenced by the RAAAF, the renin-angiotensin-aldosterone system.
Right.
Conversely, when blood volume gets too high, the heart actually releases natriuretic peptides. These hormones signal the kidneys to excrete more sodium and water, helping to lower blood pressure.
Fascinating. And the gut.
Don't forget the GI tract. It secretes and reabsorbs massive amounts of fluid every single day. So things like diarrhea or vomiting can quickly disrupt that balance and lead to major fluid and electrolyte losses.
Okay, so even with all that regulation, imbalances do happen. Let's dig into the two big ones. Fluid volume deficit and fluid volume excess.
Okay, fluid volume deficit, FVD, something called hypovolemia, is essentially a loss of body fluid. Could be from vomiting, diarrhea, hemorrhage, or maybe just not enough intake. The key manifestations you'll often see include thirst, dry mucous membranes, maybe decreased skin turgor, though that's less reliable in older adults.
What are the more critical signs?
Critically, you'll often see postural hypotension dizziness when changing position and a rapid thready pulse. Urine output will likely be decreased and concentrated. For management, the goal is to replace the lost fluids and electrolytes. Offer with isotonic IV solutions like 0.9% sodium chloride for moderate to severe cases.
And the opposite, too much fluid.
That's fluid volume excess, FVE, or hypovolemia, usually from excess intake or maybe abnormal retention, like you see in heart failure or renal failure. Here, the most consistent sign is weight gain. That's huge. You'll also likely see a bounding pulse, elevated blood pressure, maybe distended jugular veins, JVD, edema. And critically, you need to listen for crackles in the lungs. That indicates pulmonary edema.
And management there.
Management focuses on treating the underlying cause, restricting fluids and sodium, and often using diuretics to get rid of the excess fluid. As nurses, our key interventions here are meticulous daily weights, truly the most accurate measure, and accurate intake and output monitoring.
Vital signs too.
Absolutely. We have to closely monitor vital signs, listen to lung sounds for those crackles, assess for edema, and importantly, implement safety measures like fall precautions if a patient has FVD and orthostatic changes.
Okay, let's zoom in on some specific electrolytes now. We really have to start with sodium, right? The main cation in our ECF.
Absolutely. Sodium need plus is just vital. ECF volume, nerve impulses, muscle function, acid-base balance. It's involved in so much. Your serum sodium level really tells you about the balance between sodium and water in the body.
So high sodium, hypernatremia.
Hypernatremia, yeah. That's when sodium is above 145 millieql. It's usually caused by not enough water intake or maybe excessive water loss. The critical insight here is that it causes cellular dehydration, especially of brain cells.
Which means neurological symptoms.
Exactly. The primary manifestations are neurological. Drowsiness, restlessness, confusion, maybe seizures, even coma in severe cases. Intense thirst is also very common. Management involves fluid replacement, often carefully with something like 5% dextrose in water to dilute the sodium. But the absolute key is to reduce serum sodium slowly.
Why slowly?
Because if you correct it too fast, water rushes back into those dehydrated brain cells, potentially causing dangerous cerebral edema. Slow and steady is the rule.
Okay, so if high sodium shrinks brain cells, low sodium does the opposite.
Precisely. Hyponatremia, below 136 millieql, is typically from sodium loss or maybe just too much water, which dilutes the sodium. This shifts fluid into cells, causing cellular swelling. And again, the main manifestations are neurological because of that brain cell swelling.
Headache, confusion.
Headache, irritability, difficulty concentrating, confusion, and if it's severe, seizures and coma can occur. Nausea and abdominal cramps are also pretty common. For management, well, if it's due to fluid loss, we replace with isotonic sodium solutions. If it's more about water excess, fluid restriction might be enough.
And severe cases.
Severe cases might need small amounts of hypertonic saline, but again, slow correction is paramount. We have to avoid osmotic demyelation syndrome. So monitor urine output, monitor neurostatus closely, and always implement seizure precautions if you suspect severe hyponatremia.
Got it. Okay, next up, potassium, the major intracellular cation. What makes K+ so important?
Potassium, K+, is absolutely essential for nerve and muscle cell excitability, particularly cardiac function. Its balance profoundly impacts the heart's electrical activity.
So too much potassium. Hyperkalemia.
Hyperkalemia, yeah, above 5.0 MEQL. Most often, this is due to impaired renal excretion. The kidneys aren't getting rid of it properly. The most significant manifestation is on the heart. You'll see classic ECG changes, tall peaked T waves, maybe a prolonged PR interval, a widened QRS complex.
And that leads to...
It can lead to life-threatening dysrhythmias, ventricular fibrillation, asystole. It's serious. Patients might also have muscle weakness or even paralysis, which can affect respiratory muscles. Management involves stopping any potassium intake, increasing excretion with diuretics or specific potassium-binding medications like Electrolyte.
And emergencies.
For emergencies, we might use IV insulin, along with dextrose, to force potassium back into the cells, or IV calcium gluconate. Calcium doesn't lower the potassium, but it helps stabilize the heart muscle, protecting it from the effects of high K+ realigners. Continuous ECG monitoring is absolutely essential with hyperkalemia, non-negotiable.
Okay, and when potassium drops too low? Hypokalemia.
That's hypokalemia, below 3.5 millieql, often from GI losses, think diarrhea, vomiting, or from certain diuretics that waste potassium. And again, the cardiac effects are critical. You might see flattened T waves, ST segment depression, maybe prominent U waves on the ECG. There's an increased risk for serious dysrhythmias and heart block.
Other signs.
Patients will also often experience skeletal muscle weakness, even paralysis in severe cases, which can lead to shallow respirations. GI motility can decrease too. Management involves replacing potassium, either orally or with IV potassium chloride, KCl supplements.
And there are safety rules for IV potassium.
Absolutely crucial safety alert for IV KCl. Always, always dilute it. Never give it as an IV push or bolus that can be fatal. Use an infusion pump for controlled delivery. Monitor the IV site very closely for phlebitis or infiltration. And always make sure the patient has adequate urine output before you start infusing potassium. If the kidneys aren't working, you can quickly cause hyperkalemia. Also, watch out for digoxin toxicity if your patient is taking digoxin, as low potassium increases the risk.
Good points. Okay, briefly, let's touch on calcium. Bones and nerves.
Right. Calcium, key T+, is crucial for bone health, yes, but also blood clotting, nerve impulse transmission, and muscle contractions.
Yeah.
Hypercalcemia, that's high calcium, above 10.5 milligdl, often caused by hyperparathyroidism or certain cancers. It tends to act like a sedative on the nervous system.
So fatigue, lethargy.
Fatigue, lethargy, weakness, confusion, progressing sometimes to hallucinations, seizures, coma. It can also cause dysrhythmias like heart block. Management involves hydration, maybe a low-calcium diet, and in severe cases, medications like bisphosphonates.
And low calcium, hypocalcemia.
Hypocalcemia, below 9.0 milligl, often seen after thyroid surgery if the parathyroid glands are affected or in pancreatitis. This causes increased nerve excitability and muscle contraction. Think tetany.
That's where those signs come in, Schwasteck's and Trousseau's.
Exactly. Key signs for nurses. Schwasteck's sign is that facial muscle twitch when you tach the facial nerve. Trousseau's sign is the carpal spasm you see when you inflate a blood pressure cuff. These indicate neuromuscular irritability. Management for severe hypocalcemia usually involves IV calcium gluconate.
Okay, and just a quick word on phosphate and magnesium. Often overlooked, but important.
Definitely. Phosphate, PO43, is the main intracellular anion. It's vital for energy production ATP. It had an inverse relationship with calcium. If one is high, the other tends to be low. Too much phosphate, hyperphosphatemia, is common in kidney disease. Too little hypophosphatemia can severely impact cellular energy, leading to muscle weakness, even respiratory failure.
And magnesium.
Magnesium, Mg2+, is key for lots of enzyme systems, nerve and muscle function. Hypermagnesemia, often from renal failure plus taking magnesium-containing antacids or laxatives, acts as a depressant. It inhibits nerve function.
So lethargy, loss of reflexes.
Lethargy, facial flushing, loss of deep tendon reflexes, muscle weakness, even respiratory depression and cardiac arrest in severe cases. 4V calcium gluconate can help counteract the cardiac effects. Hypomagnesemia, low magnesium, is common with chronic alcohol use or significant GI losses. It often looks a lot like hypocalcemia, muscle cramps, tremors, hyperactive reflexes, confusion, seizures, and potentially serious cardiac dysrhythmias like torsades de pointe. The nursing takeaway for both phosphate and magnesium is that while maybe less common day-to-day than sodium or potassium issues, their imbalances often have critical neuromuscular and cardiac implications you absolutely have to recognize.
Right. Okay, shifting gears slightly to another critical balance. The delicate dance between acids and bases in the body. It all comes down to pH, doesn't it?
It really does. pH is simply a measure of hydrogen ion H+ concentration. It tells us how acidic or alkaline the blood is. Normal arterial blood pH is incredibly tightly regulated, right between 7.35 and 7.45.
So below 7.35 is acidosis.
Acidosis, yes. And above 7.45 is alkalosis. Even seemingly small shifts outside this narrow range can be life-threatening.
And the body has, what, 3 main ways to keep this pH in check?
Precisely. 3 key mechanisms. First, you have the buffer systems. These are the fastest responders. They act immediately, chemically, to bind or release hydrogen ions, basically neutralizing strong acids or bases. The carbonic acid bicarbonate system is a major player here.
Okay, fastest. Then what?
Second, the respiratory system. The lungs are quick regulators of CO2, which acts as an acid in the body, carbonic acid. If you have too much acid, your lungs increase the rate and depth of breathing to blow off more CO2.
Hyperventilation.
Right. And if the body is too alkaline, respirations might slow down to retain CO2, increasing acidity. This response happens within minutes.
And the third system?
Third is the renal system, the kidneys. They're slower, taking hours or even days to fully kick in, but they are the most powerful and can provide long-term correction. They do this by reabsorbing bicarbonate, which is a base, and excreting hydrogen ions, acid.
So buffer, lungs, kidneys, working together.
Exactly, working in concert to maintain that narrow pH range.
So what happens when these systems can't keep up? That's when we get the 4 main acid-base imbalances, right?
That's it. You get imbalances. Respiratory acidosis happens when there's too much CO2 building up, usually from hypoventilation, maybe due to COPD or opioid overdose. This lowers the pH. The kidneys try to compensate by holding on to bicarbonate.
Okay, alkalosis.
Respiratory alkalosis is the opposite, too little CO2, usually from hyperventilation. Think anxiety attack, maybe high altitude, or hypoxemia triggering rapid breathing. This raises the pH. Compensation here is less common or effective.
And the metabolic ones.
Then you have metabolic acidosis. This isn't about CO2. It's either an accumulation of other acids like ketones in DKA or lactic acid in shock, or it's a loss of bicarbonate, maybe from severe diarrhea. The pH drops. Here, the lungs try hard to compensate by increasing respirations to blow off CO2. Those deep, rapid breaths are called Kussmaul respirations.
Oh, right, and metabolic alkalosis.
Metabolic alkalosis is usually from a loss of strong acid, Think prolonged vomiting or gastric suctioning or maybe gaining too much bicarbonate, like someone taking tons of baking soda. The pH goes up. The lungs try to compensate by slowing down breathing to retain CO2, but there's a limit to how much they can do that because you still need to breathe.
So interpreting those arterial blood gas, or ABG, values is a critical nursing skill here.
Absolutely critical. ABGs give you the objective data.
How do we quickly interpret those results? Can you give us the essentials?
Yeah, the essential takeaway for ABGs is really having a systematic approach. Don't get overwhelmed by the numbers. First, just look at the pH. Is it low, acidosis 7.35, or high, alkalosis 7.45, or is it normal? Second, look at the PaCO2, that's your respiratory component. Is it going in the opposite direction of the pH change? If yes, it suggests a respiratory problem. Third, look at the HCO3, the bicarbonate. That's your metabolic component. Is it going in the same direction as the pH change? If yes, it suggests a metabolic problem.
So Rome, respiratory opposite, metabolic equal.
Exactly. Rome is your friend here. Respiratory opposite, metabolic equal. That helps identify the primary problem.
Yeah.
Then, the final step is to look for compensation. Is the other system, the one not causing the primary problem, trying to counteract the change? For example, if you have metabolic acidosis, low pH, low HCO3, and the PaCO2 is also low, that means the lungs are blowing off CO2 trying to help. That's compensation.
Partial or full compensation.
Right. If the pH is still abnormal, it's partial compensation. If the compensatory mechanism has managed to bring the pH back into the normal range, 7.35, 7.45, even though the CO2 and HCO3 might still be abnormal, that's full compensation. It's about putting those pieces together, pH, PaCO2, HCO3, to tell the whole story of what's going wrong and how the body's trying to respond.
Okay, that's helpful. So beyond just recognizing these complex imbalances, what are our key nursing interventions overall?
Well, our general management for pretty much all these fluid, electrolyte, and acid-base imbalances involves a holistic approach. It starts with a really thorough assessment, looking for those clinical manifestations we've talked about, identifying risk factors.
Being prepared.
Absolutely. Being prepared for potential complications, like needing resuscitation or respiratory support. Then, it's about meticulous administration of prescribed vitally fluids and medications and managing any cardiac dysrhythmias that might pop up.
In labs. Diet.
Yep, providing appropriate diets if needed, and accurately obtaining those crucial laboratory specimens. And critically, ensuring a safe environment, especially for patients who have neurological or neuromuscular symptoms from these imbalances. That means things like fall precautions, maybe seizure precautions.
It's about anticipating problems.
Exactly. Anticipating problems and protecting the patient while the underlying imbalance is being corrected.
Now, a major intervention we keep mentioning is fluid and electrolyte replacement, often through IV fluids. What are the main types we actually use?
Right, if IV fluids are a cornerstone, we mainly classify them by their tonicity, which is just their concentration compared to our own blood plasma. Hypotonic solutions like 0.45% ACL, half normal saline, are less concentrated than plasma. They dilute the ECF and cause water to move into cells.
So you'd use that for hypernatremia.
Typically, yes, for cellular dehydration like in hypernatremia. But you have to monitor carefully for signs of cerebral edema, that fluid shift into brain cells. Isotonic solutions like 0.9% ACL, normal saline, or lactated ringers, LR, have about the same concentration as plasma. They primarily expand the ECF volume.
For fluid deficits.
Ideal for fluid volume deficits, yeah. Normal saline is also the only solution that's compatible with blood transfusions. LR is great too, often used in surgery or for burn patients, but needs caution in liver failure or hyperkalemia.
And hypertonic.
Hypertonic solutions, like 3% ACL, are more concentrated than plasma. They draw water out of cells and into the ECF. These are used cautiously for specific situations like severe symptomatic hyponatremia or sometimes in head injuries to reduce brain swelling. But they require very close monitoring for fluid volume overload.
So it's crucial to know the tonicity.
Absolutely. You must always know the tonicity of the fluid you're hanging and understand why that specific type was ordered for that patient. It dictates how fluid will shift in their body.
Okay. And finally, we often administer these fluids and lots of meds through central venous access devices, or CVAs. What's the critical take-home message for nurses about these lines?
CVAs are incredibly useful tools. They're catheters placed in large central veins, usually ending up near the heart in the superior vena cava. They give us reliable access for long-term therapy, vesicant drugs, nutrition, monitoring, lots of benefits. But the critical take-home, I think, is really twofold: infection prevention and meticulous care to maintain patency.
Because the risk of infection is higher.
Much higher risk of serious bloodstream infection compared to a peripheral HOV, because that catheter tip is sitting right in the central circulation. So, strict sterile technique during dressing changes is non-negotiable. Using chlorhexidine for site care is standard, and you have to disinfect the hubs, the access ports, vigorously before every single access.
And keeping them open. Flush them.
Yes, maintaining patency is key to avoid occlusion. This usually involves flushing the catheter regularly with normal saline, often using a specific push-pause technique which creates turbulence to help clear the line. And importantly, always use a 10 milliliter larger syringe for flushing a central line to avoid excessive pressure that could damage the catheter. Never force a flush if you meet resistance.
What about PICC lines specifically? Any special considerations?
PICCs, peripherally inserted central catheters, are very common. They go in an arm vein, but the tip is still central. They have lower infection rates than some other central lines, but maybe a higher risk of thrombosis or phlebitis at the insertion site. And a crucial safety point nurses must always remember: never use the arm with a PICC line for blood pressure readings or routine blood draws. That can damage the line or affect readings.
Good reminder. So overall, CVAIDs need careful, protocol-driven care.
Absolutely. Understanding the specific type of CBAD the patient has, adhering strictly to institutional protocols for care and maintenance, that's paramount to preventing serious complications like infection, occlusion, or even air embolism.
Wow, okay. We've really distilled some incredibly dense but vital information today, from the basic movements of water and electrolytes, through the complexities of acid-base balance, and into the practicalities of 5E therapy and CVA care.
Yeah, it's a lot, but it's so clear that understanding these concepts isn't just, academic textbook stuff. It's absolutely critical for providing safe, effective, and often truly life-saving patient care. Being able to recognize those subtle signs of imbalance, knowing the why behind them, the pathophysiology, and then implementing the right nursing interventions. That's how we help restore homeostasis and promote patient well-being.
Absolutely. It's about connecting those dots. And as you, our listeners, continue your nursing journey, always remember how interconnected these body systems are, which leads to a final thought. Given that intricate balance, what might be the first subtle clue a nurse notices in a patient, maybe even before the labs come back, that suggests their body is just beginning to lose that fight for fluid, electrolyte, or acid-base balance? That kind of quiet gut feeling that something isn't quite right.
That's a fantastic thought to ponder. It really highlights the importance of sharp assessment skills and, yeah, trusting that nursing intuition sometimes. Keep that curiosity alive.
Definitely. Thank you so much for joining us on the Dup Dive today. We really hope this has equipped you with some valuable insights you can take into your practice. From all of us here on the Last Minute Lecture team, thanks for listening, and keep diving deep into knowledge.